So you see, when you are doing outdoor clinic as a gastroenterologist or even as an internist, you see a large number of patients who present with the abdominal symptoms. See, most of these patients have functional disorder. Functional disorder means that a demonstrable or provable organic structural defect is not present, that by examination or even by investigation, we generally do not find any abnormality which can be an explanation for all these patient symptoms. But you see, of these patients, we have to see is there any patient which we are going to miss who has a symptom overlap with functional disorders. For example, patient of malabsorption syndrome may have features which are very similar to the patients who got functional disorders, like patients who got functional diarrhea. So you have to see among these patients, are we really missing a patient who's got an organic disease? So if you have this question, then you should look for certain things. If they are present, they should be actually actively looked for if they are present or not. For example, look for the presence of weight loss. Weight loss, that is unexplained weight loss. There may be an explained weight loss. The patient has been trying to lose weight, but if you see the patient has unexplained weight loss, this should prompt you to look for an organic cause. Then if the patient has history of fever going on, if the patient has nocturnal symptoms, if the patient is bleeding or showing signs of anemia, or if the patient has lumps and bumps, there are masses in the abdomen, or the patient has enlarged lymph nodes or things like that, you should look for these red flags. If these are present, you should investigate the patient about the presence of organic structural defects which could explain the patient's symptoms. Now, today we are going to discuss a patient who presented with abdominal symptoms. She was a 20 years old lady. She was going on with abdominal symptoms, that is distension and bloating and frequent loose motions for last many years. And on examination, I found that she was slightly pale. And when assessment for pallor was done, it turned out to be iron deficiency anemia. Now, there was no visible cause for iron deficiency anemia. Her nutrition was good. The hygiene was good. The patient did not have evidence of leaking of blood either from the GI tract or the genitourinary tract, or patient did not claim to be an area where the helminth infections or worm infections are high. Anyway, stool examination did not support the diagnosis of worm infestation. So we started looking for what could be the possible cause of her iron deficiency, and during that we found that her tissue transglutaminase antibodies were positive in high titers, both IgA class and IgG class. So a diagnosis of celiac disease was made, which was later on confirmed with the histological examination of the small gut biopsy. So this patient is suffering from celiac disease, which could be responsible for her clinical symptoms. Now, what is celiac disease? Celiac disease is a disease in which there is allergy to some components of the grains like wheat. This is gluten. The patient has gluten sensitivity. Now, where this gluten is found, this is found in different type of grains we eat. Classical is the wheat. It's also present in barley and rye. These are natural grains. There is a synthetic grain which has been created by combining both wheat and rye. This is called triticale. So patients using wheat, barley, rye, or triticale, they can show manifestation of celiac disease if they are suffering from celiac disease. Celiac disease in these patients is associated with an HLA, DQ8 and DQ2. So these patients tend to have allergy to wheat, and then they have multiple problems. The symptoms generally are related to the GI tract. Patients have features of malabsorption. That is, there is failure of growth, they remain stunted, then they can have diarrhea because of malabsorption, bloating and distension, and similar features. And you see the disease has shades and grades. Some of the patients may not manifest with classical features of celiac disease. That is, they do not show stunting of the growth. They may be normally grown. But you see, in any patient, when you find that there is unexplained iron deficiency anemia and an unexplained osteoporosis or bone disease. So unexplained iron deficiency anemia, development of premature osteoporosis. You should look for the presence of celiac disease. Now, as I told you, there are symptoms. Patient has growth retardation. There are abdominal symptoms. You see, some of the patients who are classically having celiac disease, the symptoms, they start when the child is weaned and the child starts having abdominal symptoms, and there is diarrhea and the growth starts getting stunted. But in a few of the patients, it's not that there is classical features of celiac disease. You may find only unexplained iron deficiency anemia and premature osteoporosis. Some of the patients may show some of the abnormal tests. For example, they may have problem with the liver. There may be an unexplained increase in the liver enzymes. The patient may even present with infertility. And you see, these are so diverse sort of manifestations that sometimes it's missed. And any patient who presents with these unusual features, you should look for the presence of celiac disease. Now, how do we investigate celiac disease? You go for some routine testing. For example, you go for CBC. That can tell you about the presence of anemia, and you can also look for the cause of anemia. Is it iron deficiency anemia? Sometimes these patients may also have folic acid deficiency. The anemia may be of composite type, that it may be microcytic and both macrocytic. So because there is problem in both folic acid absorption and iron absorption. Then look for the presence of calcium. They may have hypocalcemia. They may have low albumin. Then specific tests for celiac disease, there are 3 classes of tests. We go for some blood tests. We go for histopathology. And we can also see some of the, as I mentioned, the HLAs. So we can go for HLA testing. Now, out of these blood tests, we go for serological test for celiac disease. Serological tests are of two types. One is the antibodies which are produced against gliadin. The anti-gliadin antibodies can be used, and then we can use antibodies which are against body tissue. For example, they are against the tissue transglutaminase, reticulin, and endomysium. These are more specific. They have got higher specificity for celiac disease. The anti-gliadin antibodies are generally no longer used in considering the diagnosis because they have more false positive tests. So we go for tissue transglutaminase antibodies or reticulin antibodies or anti-endomysial antibodies. And if two of these are present, the likelihood of patient having celiac disease is very high. And then we can have small intestinal biopsy. We can go for the biopsy of the small intestine. We can use the upper GI scope, and you can have duodenal biopsy, and we go for the histopathology. What we see in histopathology is that there is increase in intraepithelial lymphocytes. The intraepithelial lymphocytes are increased. And second thing is there is atrophy of the villi, villus atrophy. While crypts, they start increasing. So the villus to crypt ratio starts becoming abnormal. So we have villus atrophy and intraepithelial lymphocytes. For this, we use Marsh criteria or for staging the celiac disease. We don't go into the detail of those. Exactly, that's the job of the pathologist. But anything which is more than 3A is very, very suggestive that this is celiac disease. So if we combine these two, we can confidently make the diagnosis of celiac disease. And then in some patients, particularly in pediatric population, the Society for Gastroenterology for Pediatrics recommends if we have these tests, serological evidence of celiac disease plus the favorable HLA, we can make a diagnosis. And you see, HLA is used in another testing situation when the histopathology and the serology is inconclusive. And if the patient has negative HLA-DQ2 or DQ8, the disease is for some other reason. The intestinal problem is for some other reason. It is not for the celiac disease. Celiac disease is seen in these HLAs, and if these HLAs are not present, that is HLA-DQ2 or DQ8, it's generally not celiac disease. So we can go for these class of testing to make a diagnosis, and then as mentioned, we can go for some ancillary tests to see what sort of defects are present in the patient. Now, what is the treatment? Treatment is avoidance. Avoid gluten. So gluten has to be avoided. Gluten is present in wheat, barley, rye, and triticale. You see, these substances are, particularly wheat, is used in some parts so frequently that many things are manufactured or prepared out of this wheat. So patient has to be thoroughly educated about the distribution of wheat in different type of foods. And in some areas where the prevalence of celiac disease is less, the patients, they tend to have problem in getting gluten-free diets. So this needs to be educated. We can have our patients get information from multiple sources. They can be given booklets. They can have, if they have access to the electronic information system, they can have this on internet and they can find out what sort of foods they contain gluten and what are the type of foods which are free of gluten. So this might be through these education systems. And in some of the patients who do not respond to the withdrawal of gluten, they can be offered short-term corticosteroids. They may be useful in these patients. So this is about celiac disease. And next time we'll come up with another interesting disease. Till then, goodbye.